And so we'll try to go through a typical case that you guys may see. This is first case of 3 little kids with Star Wars. So again, let me just disclosure, this is not Kylo Ren. This is just a graphical representation of a 35-year-old guy. So 35-year-old male who goes to the emergency room with sudden onset tachy palpitations, headache. He was very clear, knew exactly when it started, 4 hours ago. No medical history, so totally normal 35-year-old guy, but was definitely drinking the night before because of a bad day at the Death Star. In the emergency room, his blood pressure is totally normal, heart rate's at 150, so no heart failure signs, lungs are clear, no heart failure, but EKG with AFib with RPM. So this is going to be interactive, but I won't torture you since there's not that many people. So the question is, what do you do next? So 35-year-old otherwise healthy, comes to the emergency room, obviously, no medical history. So 1, stab, DC cardioversion. 2 is give him IV metoprolol, try to slow him down. And then as long as he's nice and slow, controlled, feels better, send him home on some beta blocker. 3 is do the same thing, obviously slow him down since he's an AFib with RPR, and then give him a little Flecainide and say, hey, listen, eventually this will go away or control it. 4, give him, slow him down, and then cardioverter. 5 is give him IV diltiazem and say, hey, listen, this is new onset AFib, you're going to come in and get the whole workup. And then 6, since it's Kylo Ren, call it generally. So anybody have any suggestions? Anybody have any ideas of what you would normally do? You're in the emergency room, so this is assuming this is full resources. Anybody want stat? DC cardioversion? Probably not. He's pretty stable, 35 years old.
Not
So-
6, yeah.
That's right. So yeah, not 6, definitely not either. You're right. This is kind of written. So so then it's probably going to be one of the rate control ones. And I think I'll be honest, seeing it on the other end, I see all of these done. On the other end, I certainly see people who get rate controlled and then sent home. I certainly see people who get admitted straight from the emergency room saying, hey, he's on a DILT drip, and then come up to the floor, and then everybody else will figure it out later on. I don't really see people start Flecainide for a new onset AFib. I think that's probably unusual, so we'll get rid of that one. And then cardioversion, I think is a potential other option. So anybody have any thoughts? So I think probably the right answer, or not, there's no right or wrong answer in this. This is more of management and seeing how I would do it, how we all would do it as a group and what's recommended. If you think about this guy as a young guy, he knew exactly when he started now. It's always tricky. And if you look at the literature that shows and talks about how good are people at knowing when they're in AFib or not, and most of them, even if they rank themselves at a 10 out of 10 as their abilities of AFib detection, still miss AFib, certainly missing AFib when they're sleeping, miss AFib during times where they may be bradycardic and are not having a rapid ventricular response, so it's not symptomatic. So it is always very possible that AFib gets mixed, but in a person or a young person who has a very clear trigger, and that trigger is probably alcohol, who has no medical history, so we're assuming his risk is otherwise extremely, extremely low. I think the likelihood that this was actually truly abrupt onset AFib just 4 hours ago is actually pretty darn high, and probably pretty reliable that his AFib burden is less than 48 hours long. In that case, I think probably the best thing to do is try to get him out of it, not just rate control. So my choice would probably be number 4. Just try to slow him down. Sometimes beta blockers or just time in general will actually convert him itself. But if he doesn't convert, I think I would probably cardioverter. Okay. Now, this gets a little more tricky. So you decide to cardiovert. What are you going to do? You're going to give him IV heparin or NOAC. It's not bad. Hour before the DC cardioversion. Not anticoagulate him at all. Or are you going to say, hey, listen, I don't know when you went into AFib. I'm going to give you Pradaxa, Pixabay, whatever, and then have him come back in 4 weeks because, to be honest, I don't want to take a risk. Or, third option, sorry, 1, 1, 2, I'll do second number 2, then would be TEE and cardioversion. I think that's certainly would be another option. So, anybody have any thoughts on that? And again, it's Kylo Ren. We don't want to hurt him because he may turn around to the light side later on. So we give him some
If
benefit
you
of
have
that.
TEE readily available, it might make sense to do that before you cardio.
Yeah.
On the
Off chance.
off chance that he's been in it longer than just 4 hours.
Yeah.
Maybe miss something.
Absolutely. Yeah. No, I think that's totally reasonable. Anybody else have any thoughts? Yeah. So I think I think it turns out when you look at it, you're saying what are the chances, and the decision line actually goes probably TE versus not, because 1 hour of anticoagulation is not going to make any difference anyhow. If there's a clot there, whether you start them on heparin or a NOAC, if there are clots there, it's not disappearing in an hour before you cardiovert. So I think the decision tree actually slows down to TE versus no TE. If you look at the guy, he's again 35 years old, presumably normal EF. Most of the time we can't guarantee that, but with a normal history, normal physical exam, no heart failure signs, even going AFib with RVR, probably reasonable. His risk is actually going to be pretty low with a very acute sign. So probably it would be safe, and we'll look at the data real quickly here, but probably it would be safe actually to cardioversion without any anticoagulation. That being said, if you did have TE readily available, and some EDs and some hospitals you certainly do, it wouldn't be unreasonable to do that. He's at low risk for complications in TE as well too. So you may argue and say, hey, why do I want to do TE on this person? You might subject them to risk. The risk is probably pretty low as well. That being said, I think it would be very reasonable to do no anticoagulation. This is one of these unusual. You don't see that many of these 35-year-olds with binge drinking and alcohol induced AFib, but when they do exist, it's probably likely. Okay, so now this is another question. So AFib either resolves or doesn't resolve. It's a very busy slide. The question is, what do? Send them home with aspirin, whether it resolves or doesn't resolve. Send them home with a NOAC, whether it resolves or doesn't resolve. Or send them home on nothing. So first onset of AFib as far as we know. And again, I'm just going to give you the idea that it's presumably that his EF is completely normal, and that his risk factors are otherwise completely normal. So his CHA2DS2-VAX is going to be 0. But he just got cardioverted. So, anyone have any thoughts? So we'll say this. I'll say aspirin is almost never going to be the choice. Probably not in this day and age. The data on bleeding complications with aspirin versus some of the novel, especially apixaban, looks like it's probably equivalent. And so because it's pretty darn equivalent in terms of bleeding risk between aspirin and apixaban, when you make that decision to anticoagulate, for the most part, you should do full anticoagulation versus aspirin alone. And a guy who's CHA2DS2-VAX 0, the maintenance part is pretty simple. After you get through the first 4 weeks or so for post-cardioversion, that's an easy answer, right? The question is, what do you do in the first 4 weeks post-cardioversion with someone who's CHA2DS2-VAX 0, who's an AFib for just 4 hours? Again, we're just taking that assumption, plus we were just cardioversion, so he didn't stroke or didn't stroke, but we're assuming he didn't stroke. What do you do with anticoagulation? So that's the question. So I'll give you the answer in a second, but probably the answer to this actually is he doesn't need anticoagulation. So this is an unusual case, and it probably makes a lot of people uncomfortable. We shocked them without a TE, we didn't give them anticoagulation during the shock, and we didn't give them anticoagulation afterwards. I'm going to show you the data that shows that's actually probably pretty safe.
It's unlikely that this episode of binge drinking is his only episode of binge drinking.
That's right.
Probably placing him at risk for being on anticoagulation.
Yeah, and that's reasonable as well. I agree. Although that being said, afterwards his CHA2DS2-VAX is still 0. So even with the CHA2DS2-VAX 0, even if he's staying persistent AFib, you would potentially say, hey, listen, he doesn't even need it after that. So, so it does. I will say this: it makes you uncomfortable. And because and everyone's seen these sequelae of AFib and strokes and thromboembolic conditions, but there are certain populations, and this is one of them, where you can cardiovert and get them out of it, and you may never have it again until he's older. Let's look at the algorithm. So this is an algorithm essentially what we just talked about management of AFib. I think the key is this is just ACLS. Whether you're unstable or stable. If you're unstable, it's easy, cardioversion. Unstable meaning chest discomfort, hypotension, signs of shock, or so forth. If you're stable, then the goal is to reduce the heart rate. That can either be done by multiple different heart rate slowing agents, beta blockers, calcium channel blockers, or so forth. If you convert to sinus rhythm out of AFib, then you're got a break. You don't have to make any more decisions because you're back in sinus. And from an acute management of AFib standpoint, that part you can decide to defer. You can either admit them to the hospital for an expedited workup, or you can potentially send them home. It all depends on what the trigger is. If the trigger is very clearly something that's not easily reversible, active heart failure, pneumonia, you're clearly not sending somebody home with that. But if it was something like this gentleman who had a binge drinking episode, then certainly that can be done down the road. If you cardiovert, everything is going to be based on both timing and risk. But to be honest, I agree with you, Dr. Anderson, is that risk, I think, is the most important. If you look at somebody's risk, timing is very difficult to say. Whether this guy had multiple AFib episodes prior that he didn't report makes a difference. But if his risk is actually low, that is what gets you. So someone who swears it's 4 hours of AFib onset, yet his risk is extremely high with a CHADS factor of 4, I'm TEing that person and probably putting them on NOAC. And that's what the guidelines would actually say. Somebody who is very low risk, who has 4 hours of AFib, probably don't need to. So that is really where it comes down to. Now let's look at thromboembolic events after acute cardioversion. This is acute AFib. This is supposed to be less than 48 hours of AFib. Look at the numbers. They're not that high, 200. The slide's kind of mixed. You can see the mean age. This is not the 35-year-old, but this is an older population. But even in this group of older population, and altogether you're looking at, 2,000 patients possibly, the rate of thromboembolic disease for middle of age 60, 65 is less than 1% in every one of these studies. In fact, some of these studies, the largest studies, have 0 thromboembolic. That's less than 48 hours. So although we fear cardioverting people, the risk is actually very low in people who are low risk and not on anticoagulation. None of these patients were on anticoagulation. So less than 48 hours. It doesn't happen that much. I don't know if there's anybody who's an ED physician here, but I know I've certainly had that call and said, hey, go to the emergency room. Let me talk to them. I will tell them cardioversion, you can go home. Because that saves them a whole weekend worth of being in the hospital. And it also gives you the best chance of success. Because the longer you're in AFib, the longer you're in AFib. This is, again, sort of a different way of looking at it. But you can look at the risk. If you have heart failure, your risk is pretty high. So this is, again, acute conversion, less than 48 hours. So this is what we were just talking about, risk. If you have risk, your heart failure, with heart failure, or something like that, diabetes and heart failure, look at your risk, 9.8%. It's really high. But if you don't have heart failure and you're less than 60, your risk of having a thromboembolic event is 0.2%. That's 5 out of 2,000 patients. Now, if all 2,000 patients had a TE, there's no guarantee that that would be 0 either. There's also no guarantee that you wouldn't be hurting less than 5 patients out of 2,000 TEs from there. So it's an interesting discussion, but very clearly I think the idea with management of acute AFib is figure out what the risk is. Once you figure out the risk, you can decide what to do. And again, this goes against this. This talks about this as well. In this study, actually, it shows that 12 hours is actually better than 48 hours. And the cut point on this actually says that if you have AFib for less than 12 hours, your risk is significantly less than if your AFib is 24 to 48. I think that makes me feel better as well, too. If you look at the animal studies, the clot starts to form in 5 minutes. So it's not like there's not potential the ability for clot in AFib, but it's your risk factor. If your risk factor is low and you have less than 12 hours, your chance of having a clot is extremely, extremely, extremely low. Okay, does that make sense? Okay. Again, just CHADS-VAC. This is pretty simple, looking at what to do with CHADS-VAC score and how to anticoagulate. I'm not going to belabor this because I know you all have patients with AFib, and again, CHADS-VAC score. So this does go over, if you look at the numbers on the adjusted rate for stroke using the transvascular. If your transvascular is 0, your yearly rate of stroke is actually pretty darn low. If your transvascular is 1, it's not trivial, it's 1.3, but it's still pretty low as well too. So that really low AFib person, which we do see once in a while, the marathon runner, the Sith Lord, they do have a very, very low stroke risk. Okay, is that clear? All right, I didn't do a picture for this one, I probably should have. 72-year-old female, typical, again, another classic, hypertension, hypertension, diabetes. Comes for routine follow-up. She's just increasingly tired, fatigued over the past 6 months. She blows it off. No big deal. She's not having that many symptoms. She's in AFib. This is outpatient appointment, just routine, shows up. You have no idea. Maybe last time you got an EKG, maybe you didn't. It's only been 6 months or a yearly annual appointment. And her ECG shows AFib, well rate controlled in the 80s. It's a little bit different story than the other person. Had no idea, we don't know how long they're going. Much older and has significant amount of risk factors. So I'm just going to go through this because of time, but how do we go through this? How do we do somebody who has AFib? How do we work them up? The idea is, honestly, is to think about symptoms. I think that's really important because we'll talk about rate versus rhythm control in just a second, but really trying to figure out what their symptoms are, trying to figure out reversible causes, etiology, things like hypothyroidism, hypothyroidism, fevers, infection, ongoing illnesses, any other triggers, treatable, and then figure out bleeding risk. I mean, to me, the idea is always symptoms and stroke risk. I mean, that's really the two big things you think about. And then reversibility, obviously, because if you can reverse it, then that's better. How do you do quality of life measurement? This is pretty difficult because there's so many different quality of life measures. You see this sort of chart over there. I brought out the one that's the Mayo score that we use a lot at Duke. It's essentially stuff that you ask anyways, but it's nice to have it in the score, to be honest. Sometimes it's really nice so you can tell, am I missing something? People gloss over symptoms really easily. And people who you think are asymptomatic really actually have tons of symptoms. But the stuff that you would ask, things like fatigue, shortness of breath, weakness, high heart rates, even the more severe ones like chest pain and heart failure, or fainting, or syncope. But once you get some sort of inventory, and I think that's a nice thing to do, is really get it objective, to figure out what are you trying to accomplish or what are you trying to do. Then what I do, what we typically do, is to see what is their rate control like with the Holter monitor, what is their risk, why do they have AFib with an echo, are there reversible causes? I didn't put labs in here, but labs, sleep studies certainly, and then your anticoagulation or your stroke risk. So for this patient, she was 72 years old, she's female, she has hypertension, diabetes. So if we go on the Transvas there, that is minimum, without knowing anything else, a minimum of 4, which puts her adjusted stroke rate at 4% per year. It's pretty high. What do we use? I think for the most part, most everybody for new starts is using a non-vitamin K as opposed to a non-vitamin K or anticoagulant. I think the data is pretty strong that, number one, they're either just as good or better. They're also a lot more, they're a lot easier to take. But there's certainly the right patient population that you may potentially use warfarin, and those are patients that have significant renal disease or other reasons for being on Coumadin. This is the question. Those are pretty straightforward. I know everyone in this room has seen plenty of patients who just walk into the room with AFib. Do they need to be hospitalized? Again, we see this as a mix all the time, where the new onset AFib goes to the hospital and gets admitted for that. I mean, I don't think it's straightforward. I think you have to look at the patient and decide if they need it or not. Sometimes it's just easier to admit them, to hurry up and get the workup going. And sometimes patients are scared. It's hard to talk to them in an outpatient appointment and say, oh my goodness, I just got diagnosed with this, now I gotta start you on blood thinners, and now I gotta figure out whether you have, I have an easy job. By the time they get to me, they've already been diagnosed with AFib, someone has already talked to them about it. So for me, it's simple, but seeing it on the front line, I think it's very difficult. But here are really the indications for hospitalization. I think the more definitive ones, and that's obviously hemodynamic instability, severe symptoms, I think bradycardia is really important. Bradycardia is really important because not just whether they're symptomatic or not, is that we need to figure out why, what happens if they convert on those cells, are they going to pass out? Why are they so bradycardic? Medications adjustments that need to be made. Active other issues, chest pain and pre-excitation are evidence of WPW. If you have WPW or evidence of pre-excitation, that could be life-threatening. All right, here's the deal. Rate versus rhythm control. It's really difficult to talk about to some extent because I think I'm biased. That's why it's difficult. I think as you go through treating AFib, the inclination is always to go back to what we've always been told with the randomized clinical trials like AFFIRM and so forth that say rate control is just as good as rhythm control. The caveat to that is that patients can't be symptomatic. Because if you're really symptomatic in AFib, whether you're rate controlled or not, it's very difficult to ignore someone who's sitting there saying, my heart rate's 70, but I feel horrible in AFib. You know, that's a kind of an injustice to them because of quality of life. But if you look at least the hard endpoints, things like mortality and hospitalizations and so forth, there's really no difference. That's important. So you have the options to figure out what you want to do, whether you want to do rate control or rhythm control. And I think it really comes down to the symptoms. That's why getting a symptom index is really important. So what do we do? What do I do? What is recommended? This is a part of the guidelines. Because rate control is preferred in elderly patients who are likely to have minor symptoms. And I think that's important. You don't want to hurt anybody. And antiarrhythmics and cardioversions and ablations have the possibility, if they have minor symptoms and they have, you know, they're potentially at risk or high risk for the alternatives, then I think it's reasonable to do rate control. But to be honest, the easiest thing to remember is that if you're symptomatic, you really should at least give the person a shot at rhythm control. You may not know they're symptomatic, but you really should. And why? Because this is a mainstay of therapy. The idea of treating AFib is to relieve symptoms, improve functional capacity, reduce morbidity and mortality. Also reduce the idea of tachycardia-induced cardiomyopathy. These are really important things, and honestly, rate control, although really good, you would be potentially missing on these major points of treatment of AFib without at least trying a rhythm control strategy. So, this is just too busy. I'm not going to go through it. The idea is simply go and try to attempt rate control for everybody. If they still have symptoms, really should go for rhythm control. Rhythm control consists of either antiarrhythmics or ablation. And to be honest, as we know and study the data, and I don't think, unfortunately, I'm not showing all that, I didn't want to get to all the details of the data on ablation and antiarrhythmics. As ablation technology gets better, I think the studies that you will see on efficacy of rhythm control will just get better and better and better. The latest ablation trials have shown efficacy at 2 years. Again, this is somewhat of a grain of salt because they're not huge randomized clinical trials, but 70–80% reduction in AFib. That's compared to antiarrhythmics, which is about 50% or so. Now, risk, and there's been studies to look at the risk of antiarrhythmics versus the risk of ablation. And to be honest, the risk of ablation is actually still pretty low. Major complications are less than 1% requiring emergent surgery or mortality. Stroke is a mixed bag. There's been some data looking at these sort of silent strokes that can happen. We don't know whether that's involved in AFib or not, but gross strokes are still very, very low. And antiarrhythmics have a pretty high mortality. When we look at things like dofetilide and sotalol, there's some studies that show a sudden cardiac death rate of 0.8% or around almost close to 1% per year on patients with class 3 arrhythmics, so not unreasonable. So, I mean, for primary care and hospice, I think the idea really is not necessarily figuring out what exact antiarrhythmic to choose. The idea is simply this, is figure out really the symptoms, really take a good inventory of symptoms. If somebody is symptomatic, I think they're worth a shot at trying to maintain rhythm control. If they feel no difference in sinus rhythm versus atrial fibrillation, and that's very clear, then I think rate control is a very, very reasonable strategy. Thank you.